Welcome to the third part of this video education session. In this, I'm going to show the 10 easy steps of performing lumbar radiofrequency. So the number one is to identify the L5S1 disc, which is down here in this particular picture, and also to identify the L5 vertebral process. So now that we identify the L5 vertebral process, most of the time this would be where the patient is lying on the table and your C-arm is oblique towards the head end to achieve a nice and clear end plate. So at this point, what we're trying to look at is the superior articular process and the transverse process. As you can see, the superior articular process to the transverse process forms an L shape, and this is for at the level of L5 to block the L4 medial branch. So as you can see, this is an L shape. The next step, so this is showing the X-ray view of how the end plates would look. The next step we are trying to do is slowly rotate the C-arm ipsilateral to the side of where you're going to perform the procedure. As you rotate, the L shape will become a C shape. So you want to stop it at the first point you're able to see the C shape. And that gives you the most medial access to the nerve. So the next you do is then you rotate the C-arm inferiorly towards the feet end, and that opens up the groove. So now you can clearly see the superior articular process and the transverse process with the groove. And that nerve is running in this groove. I call this as a running strip. What you're trying to aim is land at the far end of the strip and be able to scrape through the ball until the distal end of the running strip. And that would give you the perfect placement of the needle for L4 medial branch radiofrequency lesioning. So how does it look on an X-ray? So this is an X-ray showing the transverse process, the superior articular process, and our landing strip. So you can either start the needle at the point where it's shown here or slightly further down if you want. But what you're trying to do is aim at hitting the bone at this point of the transverse process and be able to just walk through the bone up to your end. So for this, you need 3 views. And I think this is going to be quite confusing as we talk through, but I'm going to try and recreate this as we go. So the first view you're looking for is the posterolateral view. This is the view where once you land the needle in the groove, you want to use this view to advance the needle. The second view is the upper and lower tunnel view. So it is basically tilting the whole C-arm to look at it from the bottom. So you're actually looking at the needle to see, is it touching on the bone and is it in the right position of the bone? And the next thing is you tilt the whole C-arm to go towards the head end, which helps us in seeing how far we can advance this needle without going into the frame. So that's just a gist of what we're going to look in the next 3 views. I'm going to go through each of these views individually. So the first view we talked about is the posterolateral view. So you've got the landing strip, you've got the tip of the needle touch the bone, and now you want to advance this needle. The way to advance this needle is get a posterior and lateral view. So the way you get this view is go towards a Scotty dog view, and once you get the Scotty dog view, if you're doing the left side, this would be 4 o'clock position on a clock, which would be here. And if you're doing a right side, it'll be 8 o'clock position. So that's why it's called 4 o'clock or 8 o'clock, depending on the side of the lesion that you're going to perform. And with this in place, you would have landed the needle here, and you want to slowly advance this needle in this groove. So this view is very useful for advancing the needle. So the next is you rotate the beam again, and you're looking at it from inferior angle. So you can see that's again the groove, and this view is very useful to see where the needle tip is. So if your needle is too medial, you can tell you need to move lateral, and if it's too lateral, you can move medial. Sometimes, for example, in this X-ray position, you can see the groove here, the needle is across, you can actually create a burn, and if you just rotate the curvature, you get a second burn here, which would be enough to denervate this nerve. So this tells you where in the curvature your needle is. So you're going to carry on. So this is how it looks, the upper tunnel view. So you can see the amount of tilt that we got on this upper tunnel view. So the next thing you're doing is you're carrying on rotating it further down. So what you're looking for is this needle touching the bone all the way through. So this view is useful to make sure that there is confirmation that your needle is touching the bone. And then you rotate the C-arm from inferior all the way to superior. So it's like you're going towards the head end. And I think now you're looking at the whole picture from the top end. And you can see the needle in position. So this we call as a 6 o'clock position. So once you rotate the C-arm up towards the head end, the needle is facing the 6 o'clock position of the clock. And you can see the needle is not too far in. So we advance the needle so that there is a little brim of bone left. So this is how it looks. So you can see there's a big brim of bone here. You can advance it to have it as a small brim. And how does it look? This is how it looks with a superior oblique view on physically looking at your C-arm. So in summary, we start, identify the L5-S1 disc. We then look at L5 vertebrae. All you're looking for is a L-shaped picture from the superior articular process and the transverse process. We rotate it laterally to see the curvature. We then rotate it inferiorly to see the landing strip. Once we got this, then we start the entry point to touch the border of the transverse process. Once you hit the bone, it is going to be quite painful. So you want to put at least 2 or 3 cc's of local anesthetic. Give a few seconds before you start manipulating this needle because periosteal scraping is quite painful. Once you got the bone contact, inject the local. Now you rotate the beam to look at a posterolateral view. As I said, if you're doing the left side, the needle will be looking as if it's a 4 o'clock. If you're doing the right side, the needle on the C-arm would look like 8 o'clock in position. And that's where you want to rotate it and adjust it. Once you got this, you advance the needle slowly. And once you're comfortable that you advance the needle, you then rotate the beam to look at it from inferior angle. While you're looking at the inferior angle, you're looking at 2 different views. Like first, you're making sure that it's in the curvature and you're happy that it's in the middle of the curvature. The next is you inferiorly oblique further down to make sure that the needle is touching the bone all the way through. At this point, you then rotate it superiorly. So when you rotate it superiorly, the needle comes at 6 o'clock position on the C-arm. And this is helping you to advance the needle slowly so that there is a very small brim of bone present. Would you do a lateral view? I think you can do a lateral view, but I would not advise the lateral view as an important view for you to adjust the needle, because if you are not a perfect lateral, then you can actually either push the needle inadvertently too far or pull the needle and make sure that you miss the target. So the best position to get the final needle position would be the superior oblique.